Thank you for watching the video presentation of our abstract on the diagnosis of bladder and outlet dysfunction and the outcome and revision rates of artificial sphincter surgery in a prospective set of 237 successive patients with post-radical prostatectomy incontinence. I am Wyndaele and I speak on behalf of Stan Linders and Peter Rosier from the Department of Urology at the University Medical Center Utrecht. I have no affiliations to disclose in relation to this abstract or in the past year. Post-radical prostatectomy incontinence is a prevalent condition which can be very bothersome in patients who are hopefully cured from prostate cancer. Underlying mechanisms are sphincter deficiency, which is present in all patients, but there is also very often an underlying bladder dysfunction. The treatment of post-radical prostatectomy incontinence consists of a first-line conservative approach with lifestyle interventions, physiotherapy and medication, and if that does not suffice, then surgery can be offered to the patients, either a male sling or artificial sphincter. Predicting the treatment outcome of the surgical interventions based on the severity of urinary incontinence and or urodynamic parameters remains very challenging. The study was performed in a tertiary referral center for artificial urinary sphincter surgery. The patient population consisted of 237 consecutive patients referred to us with post-radical prostatectomy incontinence, on average 50 months after their prostate procedure. The time frame was 2006 to 2019. As we are a referral center, all patients received the same diagnostic workup and follow-up. The dysfunction of bladder and sphincter is evaluated through a treatment simulating urodynamic investigation in which the situation after sphincter implantation is mimicked. This allows evaluation of bladder function after the procedure. Cystoscopy is also performed in all patients. The follow-up is standardized, allowing outcome and revision rate evaluation. Urodynamic investigation prior to artificial sphincter implantation showed an overall maximum systometric capacity of 355 milliliters in these patients. There was a very high prevalence of bladder dysfunction. 43% of patients had an abnormal sensation of bladder filling. 39% showed detrusor overactivity on urodynamics, and 54% had a decreased bladder compliance. Almost half of the patients also strained during voiding. Based on this urodynamic investigation, 148 patients received an artificial sphincter and 89 were advised against. The main differences in the urodynamic parameters were that the maximum systometric capacity was higher in patients receiving an artificial sphincter. Patients advised against had more abnormal sensation of bladder filling and more detrusor overactivity. The flow rate, on the other hand, was higher in patients receiving an artificial sphincter, and pressure required to produce this was lower. Remarkably, there was no difference in the amount of leakage on the PAT test, in the history of radiotherapy, in bladder compliance reduction, or the bladder contractility index. The contraindication according to the guidelines was bladder outlet obstruction based on the bladder neck stenosis or urethral stricture, which had to be resolved before implantation of an artificial sphincter was considered. Using treatment simulating urodynamic investigation to select and counsel patients prior to artificial sphincter implantation led to quite good outcomes. Complete continence was achieved in 73% of patients. Bothersome incontinence after the procedure was reported by 15% of patients, and additional interventional management was required in 11%. The revision rate with a follow-up of 5 to 10 years was 19% and correlated with the presence of detrusor overactivity or reduced bladder compliance prior to the implantation. A history of radiotherapy and straining to empty the bladder were no factors in the revision rate. The concluding message is that treatment simulating urodynamic investigation is feasible without extra patient discomfort and allows to select and counsel patients prior to artificial sphincter implantation. This leads to good outcomes with a high reported continence rate and a low need to additional interventional management or revisions after a 5 to 10 year follow-up. Thank you for watching this video.